this chapter, and I'll make that bigger for you if something like this is so. So that was just to get you kind of started with that. And lecture chapter is going, so. There are several anxiety disorders that just fall kind of under the anxiety by itself, and generalized, and social anxiety, and phobias. We'll talk about them a little more in detail. Obsessive compulsive traits versus obsessive compulsive disorder. You can have obsessive compulsive traits, but not being diagnosable as having the disorder. The person with the disorder really cannot function in life because they have so many compulsive behaviors that they have to complete during the day to control their anxiety, that they really cannot work or get much of anything else done due to their compulsive behaviors. Whereas if you have obsessive compulsive disorders, you can be someone who's very perfectionistic, which, we would think of that actually as complimentary. However, someone who is a hoarder, I don't know if you've ever watched those shows on TV, some of those people have some pretty good, important jobs, and I saw one who was a physician, I think a surgeon, and you would think that he had his life perfectly in order until you got into his house, and then realized he didn't. But that was an example of someone who had, some traits, but not the disorder, because he was still functional in life. People who do the skin picking, exfoliation, you can usually spot them, and it's anxiety related. It's all anxiety related. The trichotillomania with the hair pulling. Some people, might pull out a area and have a bald spot as big as a silver dollar from pulling hair, and it's something that they do to help themselves not feel stressed. So those are traits, but they could still hold down a job and have relationships. The trauma and stressor related disorders are the PTSD and the acute stress disorder. We'll talk about those a little bit more. Under the somatic, I don't know, we might get to a couple of those, and then a couple of the disassociative. And I realized that wasn't on your slide. I added the disassociative. It fell off. Or I failed to type it. One or the other. Probably failed to type it. Okay. So, all of these are anxiety-driven disorders. So we know it's subjective, but there are objective behaviors that we, as nurses, can see, but we can't really experience what that individual is experiencing. But they're having emotional pain, regardless of which of these diagnoses they have. There's a lot of apprehension, fearfulness, feeling powerless to control what's going on in their life. And so they have behaviors that are intended to help relieve their anxiety. It's not, sometimes it helps temporarily, sometimes it doesn't. Anxiety is contagious, and I know you all know this from talking to each other on the days that you have exams, that if you spend a little time chit-chatting at 4 or 5 of your classmates who are really wound up and really anxious, you will find yourself becoming more anxious as well. So the reason I put this here, I usually don't spend much time on anatomy and physiology and that sort of thing, but because these medications that people take are designed to address the situation. So when people are under a lot of stress, they have increased epinephrine and norepinephrine turnover. And the drug class SNRI cuts down on the norepinephrine turnover and serotonin turnover so that you have higher levels of norepinephrine and serotonin. And then we have reduced dopamine released in our brain, and we're feeling very stressed. And I think dopamine is one of those kind of happy, relaxed kinds of neurotransmitters. The sympathetic nervous system gets going with increased pulse rate and that sort of thing. We also have a decrease in serotonin transmissions, and our blood sugar usually holds. So the primary actions of some of the antidepressant and anti-anxiety medications are to address those substances. So that's the real reason for this slide. We went through this last semester, or just a little bit, maybe that I added to it because this book had it represented a little bit differently. In the first stage, the alarm stage, your anxiety level is probably just 1 to 2, which is mild to moderate. And that's when we're all relatively functional, we work pretty well, we're motivated. You know, mild actually motivates us. Moderate, we probably aren't going to do our very best work, but we were still going to do reasonably well. And then at the resistance phase, the anxiety level is 2+ to 3+. And I know that's kind of different. In this book, we didn't talk about it in state. We said mild, moderate, severe to panic, I think. And this book, we also have numbers assigned. So that's a 2+ to 3+, which are the moderate and severe. And then the exhaustion, when you're just really, maybe you've been under a lot of stress for quite a long time and you're getting to the point where you just cannot keep up and you're starting to decompensate, I guess. Your work performance is poor. Maybe your relationships are not doing well. You're getting sick a lot more. So you're really just kind of coming down, getting worn down in that exhaustion phase. And then the last, panic, you really just shut down mentally and have no rational thought processes. So we don't want to spend any time in 3 and 4 if we can help it. Can't always help it, but we don't want that for our patients, we don't want it for ourselves. Okay. I think I just said this. So there's a disorder called generalized anxiety disorder. It says in our chapter that the anxiety disorders are the most common of all of our psychological disorders. And there's a table, let me see, it's on page 310. It tells you what percentage of people are in the United States are affected in the 12-month period by this disorder, and then whether they're more often to be male or female. And it breaks down a little bit, but I think generalized anxiety disorder is something like 2%. So anyway, when you look through there, depression seems to be the highest, but anxiety disorders as a group is far and away higher than the others. Higher than substance abuse, which I might not have thought. But with generalized anxiety disorder, this person is affected every day. They worry about all kinds of things, and it becomes habitual. So their ability to concentrate is affected. They're irritable, having often memory problems develop. They're causing them not to do well at work or school. Physical symptoms there, muscle tension, fatigue, insomnia. This, I believe, is most often diagnosed in women, and often it was either early 30s or late 20s, most often. That doesn't mean that's the only time, but that means that it is the most common. And a lot of the people who are, oh yeah, it said the median age is 30 years of onset. And a lot of the people who are diagnosed said they have really felt anxious and nervous all their lives, but it has gotten to the point that they've sought help, and maybe it's gotten worse, so that they're, having to seek some assistance for it. So it's causing them impairment in their relationships and their jobs. Research shows there's a high correlation between generalized anxiety disorder and major depression. So it may have some neurobiological mechanisms. They also say that worrying allows the individual to avoid more threatening images and emotions. And an example might be they have very strict, demanding parents, perhaps as a child, and they have some kind of things that they really prefer not to think about from their childhood. This kind of substitutes itself for that. The individuals feel sort of like failures. They feel like they don't measure up very well and tend to be somewhat withdrawn. So as a nurse, if you're working with someone with generalized anxiety disorder, you want to provide support, some reassurance that there are things that can be done to improve their situation, show some empathy and acceptance. If the anxiety is too high, they really cannot do any problem solving or develop, experience growth in dealing with their problem until it's reduced. And we want them to develop adaptive, good coping skills and responses. So you're going to hear some repetitions here, and I'll go pretty fast because some of the nursing interventions are the same for a lot of these. The calm, quiet environment, getting them to discuss their feelings, helping them identify possible causes for those feelings, listening really carefully to what they tell you, and because there is that correlation with depression and generalized anxiety disorder, you want to know if they feel suicidal, and then trying to get them involved in some activities and things that are going on in the unit and keeping them a little bit busy so they don't have time to fret about things. A lot of times the things that they're stressing about or haven't happened or aren't even going to end up happening. People just get into the habit of having something, waking up in the morning and start worrying about, well, what if this happens today? What if that happens today? What if my car doesn't start? What if, what if? And we want them to learn to think, well, what if something good happens today? What if, I keep on top of my work list today? So we want them to have more positive thoughts. Okay. So talk to them about they've been successful at in the past with coping mechanisms and what works for them now. I don't know if any of you all set yourself doing this, but I do find myself kind of holding my breath or breathing shallowly when I'm feeling stressed. And One of the things I'm really bad about is picking up on someone else's stress. And when we were doing check-offs today, if I was helping someone who was fairly anxious, a couple of times I caught myself holding my breath. And I think, that's not good for my blood pressure, I need to breathe. So, and I'm thinking I should be telling them to breathe, instead I'm telling myself to breathe, because I'm feeling their stress, which, no, I don't wanna feel your stress, I'm sorry. I've got stress of my own. No, I do feel your stress, and all of your teachers do. But we need to work on ourselves, we're all work in progress. And we can, just telling us to breathe and helping our clients do that too. I don't know if any of you all catch yourself not breathing well, but I do. So helping them come up with some alternative solutions to, and instead of those negative thoughts that are going through their heads, and some positive things. Relaxation exercises are big here. Having kind of a plan for when they're feeling stressed out and anxious and worrying about things, what they're gonna do instead. Don't wait till you're in the middle of it to know what to do, but to have a plan. And exercise does a lot to help with insomnia for a lot of people. They say not to exercise really late at night, but exercise during the day. Things like endorphins make you feel better, but also you get some relaxation of those tight, tense muscles. So milieu management, and got panic disorder on here too. Cognitive behavioral therapy is the gold standard. I remember one of you saying that for GAD especially. And it employs strategies to manage their psychological and physiological symptoms. So they're changing their internal dialogue from negative to positive. I know you guys have heard that before. Behavioral techniques like meditation and yoga and mindfulness. Paying attention to what's going on inside your brain, and also correlating it with how your body feels. When you're feeling really anxious, are your hands sweaty? Do you feel like your heart has sped up? We have that biofeedback where people with high blood pressure can do relaxation exercises and then recheck their blood pressure and it drops. So it's very possible and very well known that people can use biofeedback to change their responses to things, and even do something as important as reduce the blood pressure. So there may be some group work on stress management and problem solving, self-esteem, so group therapy can be good. Now for panic, there are different things. The cognitive behavior therapy also, but physical activity is really, really good for people who tend to have a panic disorder or panic attacks. And there are medications for that as well. We'll talk about how the medications might differ from one to the other on another slide. And then having a routine that they can kind of rely on and fall back on is important. Some people with panic attacks might not have more than 1 or 2 panic attacks a year. Other people might have 2 or 3 or 4 a week. So that person probably isn't able to keep a job and function very well if they're having them that frequently. So they're gonna need a lot more treatment management than someone who doesn't have them very often. Okay, so the pharmacology bit. So the SSRIs are ordered often for generalized anxiety disorder. Also the NSRI. I don't know, doesn't sound like that's what it is, but it is. It affects both norepinephrine and serotonin reuptake. Benzodiazepines are really not a good idea for generalized anxiety disorder because they're really for short-term use only. And we don't want to get someone addicted to benzos, and it's very easy to do, very easy to happen, even if they're not taking them more often when they're prescribed. They have to be used short-term. There's a medication called buspirone that is used for generalized anxiety disorder. It is not addictive. It's not a benzodiazepine, but it helps them with their apprehension and worry. However, you have to take it all the time. You can't just take it when you're not feeling well, which is true of the SSRIs in SRI too. And it takes a couple of weeks to reach the full benefit of the medication. So it's not a quick fix for anything.
What was that medication called?
Buspirone. So panic disorder is a common disorder in psychiatric care. Women twice as often as men. When it happens, that person may feel like they're dying or going crazy. They often think they're having a heart attack because they have palpitations, they have shortness of breath. According to our book, it's usually over within 10 minutes. I think our book last semester said it takes sometimes lasts as long as an hour or two. It's really so horrifying for the person the first couple of times this sort of thing happens. Maybe it happens in the grocery store. They're probably not ever going to go back to that grocery store, and they're afraid it's going to happen again in the grocery store. Maybe it happens if they're at a sporting event, just out of the blue that, it hits them somewhere where they're not expecting it, and they tend to avoid those places, understandably. I think this is pretty repetitive of what it says below that about the neurotransmitters. So commonly used are SSRIs for long-term treatment of panic disorder. They can, with panic disorder, use the benzos short-term, like alprazolam and lorazepam, but that's just because panic is there and then it's gone. And they can have a pretty rapid response to a benzodiazepine. Within just a few minutes, they can get some relief with that. And obviously you wouldn't use the buspirone for panic attacks. You would use it for generalized anxiety, but not for panic because it has to be taken all the time and it doesn't work fast. Okay. So agoraphobia, social anxiety, we'll go through these kind of quick. Phobias are pretty common. Agoraphobia is people who are afraid to go places by themselves. Sometimes they're afraid to be in a crowd, like a movie theater or a sporting event, and tend to become a recluse and stay in their home. They're afraid they would get trapped in some of those places if something bad were to happen, and they could not escape. Social anxiety disorder, also known as social phobia, people who fear like going to parties, events, maybe at work where they're going to have to mix with people they don't know very well. I used to tell my husband when I had to go to a work function with him, don't leave me. Before we left the house, I'd say, do not leave me, because he was real good at wandering around and talking to strangers, and I didn't want him to get left behind and be standing with someone that we had absolutely nothing to say to each other. So I threatened him with his life if he ran off. I really don't have social anxiety disorder. I just don't happen to like getting I might have it.
Yeah, me too. I was like saying this, but
If you're worried about being bored more unlikable or maybe whatever. They're just afraid they're not going to, they're gonna be the ones, what do they call that?
I self-diagnose
A
myself
wall-
here.
I don't wanna be one. Okay. So, cognitive behavior therapy can help, and systematic desensitization. We'll talk a little bit about that. There are a couple of medications, clonidine and propranolol. Sometimes I said that they can be taken prior to an outing, like you're doing, if you have social anxiety disorder and you know you're gonna have to go,
I need
to a
some.
banquet where you're gonna have to eat with people you don't know, you're gonna have to chit chat with people you don't know. You might need the medications, you might be given just for the, for that day, that night. Is there quantity of propranolol? Yeah, they're on the slide, and, propranolol is an antihypertensive, clonidine is too. But they're given in low doses for social anxiety disorder, and they might keep someone from their hands being sweaty and feeling faint. It may just reduce some of their symptoms, help relax them a little bit. And if they have either of these disorders, they're probably going to be on an SSRI. So I think you're getting the picture that SSRIs are used for a lot of these. Okay. Oh, I went the wrong direction, sorry. Now, behavioral therapy phobias, behavioral modification. So I use an example of systematic desensitization here. I said one gentle tug, unleash, and then I read that, for a little part of my brain went, tug, what was I thinking? It's a dog, little dog. So if you have a horrible fear of dogs in general, they might start with you being around a little gentle dog that's not aggressive. You know, Chihuahuas bite more people than German Shepherds do, so I wouldn't recommend a Chihuahua. But, you know, some nice little dog, maybe it's on a leash, and you would just kind of be in the same room with that dog a couple of times a week, and then work your way up to not being on a leash or something like that. So that's progressive exposure to decreased fear, is that systematic desensitization. Now, implosion therapy is the opposite. You just kind of throw that person into the situation that that they're so terrified of. And they only do this with people who are physically healthy. So I said the psychologist might take that person, if they were gonna do implosion therapy, to a dog park that's full of dogs that are not on leashes. And so that would be, implosion therapy.
So why do they, like,
Why would they do that?
yeah.
You know, I think that's a very good question. Victoria asked, why would you do that? Because it seems kind of cruel. I'm guessing, and I don't really know, I'd have to research it a little more. I'm guessing that the systematic desensitization just wasn't really working, you know, they weren't, maybe other therapies, other modification wasn't working. And I'm guessing this one's not real popular, you know, because like if, I don't think I would agree to that. If there was something I was terrified of, that throwing me into a room full of clowns, if I was afraid of clowns, you know.
I feel like they'd have like a panic attack.
Yeah.
Just die.
Have a heart attack or die or something.
That's why they have people fully healthy.
Yeah.
I have a legit phobia, so like, if this were to happen to me, like, I would die.
Yeah.
Like,
Yeah.
die.
Yeah, it would be, I can't think that this is very popular. The systematic desensitization makes more sense. Like people who are afraid of elevators, they might eventually work up to just one floor, and it's a fast elevator, you know, and they practice till they get to the point they can do one floor or something. But, you know, this whole throwing people in head first, it's sort of like someone who can't swim, so you just throw them in deep into the pool or something.
My grandma did that too.
Yeah, some of them
Eventually
really
would trigger a heart attack.
It sounds kind of
Sounds like a whole
cruel.
bunch of lawsuits waiting to happen.
Yeah.
Right.
Someone said it sounds like a lawsuit waiting to happen. I think, I would think so My daughter's an attorney and she loves it when psychiatrists do this. No. Making that up. Making that up. Okay. So treatment for phobias is generally outpatient. We talked about these medications, I'm just giving you a little more in-depth about them. The propranolol is not used as often as the clonidine. It says rarely because of side effects, but yeah, it could be. The clonidine is, I've heard that being used fairly often. So. People aren't normally hospitalized because of phobias, but they might go to outpatient, they might go to therapy because they want to get over their phobia. Okay, obsessive compulsive traits, more common in men and in the eldest child of the family. So if you just have the trait, you might lack spontaneity, you might be very formal in your interactions with other people. You might have a hard time delegating, and I think that has to do with maybe being perfectionist. A little bit rigid and stubborn just because of sort of like my way's the right way. You know, but often this person might be a very good worker because they're art perfectionists and it may get in the way of them getting tasks completed because it's never perfect enough. But and these might be people who have a hard time getting rid of things. And I think we all are kind of on a continuum. Some people toss stuff right and left. Other people, I keep it for a little bit too longer than I should. Other people maybe years longer than they should. But anyway. So it's important to know there's a difference between traits and illness. I think we'll do the disorder and then we'll take a break. So obsessions are the recurrent or persistent thoughts or impulses that are intrusive and unwanted, and they may be so severe that you can't really function because of those thoughts that keep coming into your head. The compulsions are the rituals that the person has to perform, trying to reduce their anxiety that's triggered by those obsessions. So this repetitive rituals like washing your hands 25 times, a lot of counting, checking locks over and over and over again, that sort of things. And if the individual doesn't make the connection between the obsessions and the compulsive behaviors. It is believed to have a genetic component, and there is serotonin dysregulation. So the medications listed here, SSRIs again. Clomipramine is a tricyclic antidepressant, but it isn't used very often anymore. It's kind of an old drug. You may run across it at St. Anthony's or Meadow Lake, even though it says here it shouldn't be used in adolescents because of an increased risk of suicide. Once in a while you'll find a doctor who will use an old drug when they've used everything else and when they're in a real monitored situation. But I'd be surprised if you run into that. Let me see. Okay, key interventions. The student who talked about this went right through the list, I think, pretty well. Don't try to take the rituals away from them. That has to be done very slowly. Like if this is someone who checks a lock 50 times, they might end up, you might get them down to 45 this week, and that sort of thing. And they have to have other activities to substitute for the ritualistic behavior, and a lot of positive reinforcement for their non-ritualistic behavior. But there have to be, they have to have explanations and warning before anybody tries to cut down on the amount of time that's spent on their rituals, or they'll get very panic-stricken. So it has to be done carefully within the milieu. You wouldn't want some rote nurse coming on that evening that says, well, this is ridiculous, I don't have time to sit here and watch this person wash their hands 20 times, so I'm not gonna let them do it. I mean, that would be not working in the milieu, not working for the client, not helping them, you probably set them back a long way. And they feel some security that's important with, within the structure of the milieu. Okay. So you're wanting to, exercise is very good at helping reduce the anxiety and helping them learn some adaptive coping. A lot of these are, like I said, repetitive. Help them talk about their feelings and solve problems, make decisions. And if they can get, involved in group work on communication and social skills, that would be great too, because usually people with the obsessive compulsive disorder don't have very good social skills. So the more they can work into working with the group, the better off they're gonna be. Okay. This is, I guess, the most important thing is that the SSRIs are at higher doses for OCD than they are for depression or other anxiety disorders typically. And it takes quite a bit longer to see benefit than what you might see with depression. So that's the main thing. All right, we're gonna stop here for a 10-minute break, so what time does that have to be? 1:33 now, by my clock, so 1:43.
There used to be a TV show about treating people with OCD.
Really?
Yeah. Like it would show them tapering off routines and getting them to a functional level.